All right, we are live. Good afternoon, everyone. I'm Nate Anderson. I'm the Executive Director for Concerned Veterans for America. We're very happy to have you all with us joining live on Facebook and on Zoom. I want to welcome you to our Veterans Healthcare Policy Forum. We're here to discuss an important topic, the manner in which America provides healthcare to our veterans. It's not only an important thing for our society, but it's an issue that directly and personally touches the lives of so many military and veteran families across this country. And we have so much to talk about today. I'm going to keep my comments brief. I'm going to get right into our introduction for our special guests tonight. So first joining us is Congressman Chip Roy. Chip Roy is representative of the 21st District in Texas. He's a former federal prosecutor and a top advisor to many prominent Texas elected officials. He previously served as Chief of Staff to Senator Ted Cruz, Staff Director to Senator John Cornyn, and Senior Counsel to the Senate Judiciary Committee. The congressman has spent numerous years outside of politics, including work as an investment banker and banking analyst, a technology consultant, and as counsel in the oil and gas industry. The congressman has also served as Vice President of Strategy for the Texas Public Policy Foundation. Representative Roy serves on the Budget, Oversight, and Veterans Affairs Committees, and is the ranking member of the Oversight Committee on Civil Rights and Civil Liberties. Welcome, Representative. Our next guest is Dr. Kris Held. Dr. Held is president of the Association of American Physicians and Surgeons. She is a board-certified ophthalmologist. She's a graduate from the University of Texas at Austin and received her medical degree from the University of Texas Medical School at San Antonio. She maintains an academic affiliation as an adjunct professor at the University of Texas Health Science Center in San Antonio. On October 1st, 2015, her practice became completely third-party free, including opting out of Medicare. And in 2018, she received the Lifetime Achievement Award from the National Association of Women Business Owners in San Antonio. Welcome, Doctor. And next up, we have Dr. Kat Lindley. Dr. Lindley is a board-certified family physician born in Split, Croatia, formerly known as Yugoslavia. She left Croatia at age 18, one day before the Balkan War started. She eventually moved to the United States, where she obtained her Bachelor of Science degree in biology at Florida Atlantic University. She pursued her medical degree at Nova Southeastern University College of Osteopathic Medicine. She finished her family medicine residency in Miami, Florida in 2007, and has been practicing family medicine since then. And then in 2017, she opened her direct primary care practice in Brock, Texas, where she resides with her family. Finally, Mr. Darin Selnick. Darin Selnick is the senior advisor to Concerned Veterans for America and an Air Force retiree where he attained the rank of captain. From 2018 to 2019, Mr. Selnick was a senior advisor to the Secretary of the Department of Veterans Affairs. His central responsibility was the implementation of the VA Mission Act, the biggest transformation of the VA healthcare system in over 20 years. For his accomplishments at VA, Secretary Wilkie awarded Mr. Selnick the Distinguished Career Award, which is the highest award a VA secretary can give. Darin has also served as a veterans advisor at the Domestic Policy Council at the White House, as commissioner on the congressionally established Commission on Care, and executive director of the Fixing Veterans Healthcare Bipartisan Task Force. Welcome, Darin. So before we get into our questions and the discussion tonight, I wanted to take just a moment and pause, because today is a particularly important day. So I want to pause and recognize October 7th. It marks the 19-year anniversary of what's called Operation Enduring Freedom, or our military response in Afghanistan after the attacks on 9/11. It's a significant day because a 19-year anniversary means that starting today, we're entering into a 20th consecutive year of military deployments, and not just in Afghanistan, but in many other countries around the world. And so that milestone adds some meaning to our conversation tonight. And particularly because, it's those service members who are going to come home eventually and become veterans. And so I want to consider that as we begin our discussion. I think that's an important thing for us to remember going into this. So my first question here is for Darin Selnick. I want to ask Darin how the Department of Veterans Affairs has changed and the way it approaches its mission, caring for veterans. Can you give us a short history, some of the reforms that have occurred recently, and how the experience of enrolled veterans has changed in the past couple of decades?
Thanks, Nate. Yeah, happy to do it. Kind of a history buff on this, having been at the VA all the way from 2001. So to understand the VA and kind of frame up where we are and the experience veterans get, we got to go back to 1996. The VA current healthcare system was set up in 1996 in the Veterans Healthcare Eligibility Reform Act of 1996, which set up the current system of priority groups and all veterans being potentially eligible for VA healthcare. Before 1996, you had to be service connected. And so in 1996, when this change was made, there was about 3 million veterans out of 25 or so million veterans that were actually enrolled in the VA healthcare system. That has now grown to 9 million veterans that are enrolled in the system. And of that 9 million veterans, there are about 3.2 million that are service-connected priority groups 1, 2, and 3. So not a lot of growth in service-connected, but a lot of growth in non-service-connected veterans who are getting their healthcare through the VA. That model I was very familiar with because I was in healthcare at the time in California. Dr. Kaiser brought his California HMO model from 1996, which was a staff model HMO, which means you just basically went to the facilities, and if they couldn't handle you at the facilities, they would select community care. That model is a pretty out-of-date model, but that is still the model that the VA has been trying to go to as it's gone forward. That model worked for a long time. Healthcare changed, the type of veterans changed, and around 2014, the model started falling apart. And because of the change in healthcare, because of the growth in the number of veterans and the capacity of the system, we started seeing long wait times and poor access. This culminated in 2014 with the Phoenix scandal and other scandals where literally veterans were put on secret wait lists and were literally dying while they were waiting for their health care. This scandal then caused the 2014 Veterans Access, Choice, and Accountability Act, which set up the first temporary choice for veterans, which was 30 days. You wouldn't have to wait 30 days, or you wouldn't have to drive more than 40 miles. If that happened, then you were then eligible for community care. Unfortunately, it was one of 6 community care programs. So it was very confusing for staff, very confusing for the veterans, which program they did, with the rules. They seemed to constantly change. And understand before that, all your healthcare in a staff model HMO was actually closely like the Britain healthcare system, kind of a socialized system. You had no choice of who you saw, when you saw. All decisions that you want to use that was based on the bureaucracy and whatnot. There were some polls commissioned, Gallup commissioned a poll, CVA commissioned a poll, independent poll, and both the public and the veterans themselves, by about 90%, said, hey, we should have more choice. And so with the Choice Act not working very well and the Choice Program not working very well, although veterans were happy to have better choice, there was set up a commission, which I was a commissioner on 2015, 2016, that looked at over a 9-month period of time, how do you reform the VA healthcare system? How do you modernize it? One of those recommendations was much more choice in the network, basically a full choice model in the network, recommendation number 1. Also with many other recommendations on how to fix the facilities, supply chain, employees, staffing, all of it, to bring it into a modern system. Had some top healthcare experts like Toby Cosgrove from the Cleveland Clinic. Those recommendations were not, although they were approved by VA and the Obama administration, by 2016 during the election, they were not implementing those implementations. I came into the administration in 2017, and it was my job both at the VA and at the White House to work on fixing those problems and trying to implement some of those Commission on Care recommendations. And what we basically did was the passage of the Mission Act in June 2018, which was implemented in June 19. The simplest way to understand what we did on the healthcare side of that Mission Act was to basically use TRICARE model as the model for things like access standards. I happen to be retired military. I am in the TRICARE model. It works very well. And so we fixed the claims processes, making sure veterans didn't get it. And following that model, we also did a new benefit called the urgent care benefit, where like DOD, you didn't have a referral authorization. If you had an urgent care situation, you would just go in the network and pick your provider. It's been very successful. We did follow the access standards like TRICARE Prime pretty closely, except for the primary care. We had a little bit longer wait time for primary care, 20 days, TRICARE 7 days. And we added mental health, which is not specifically listed in the TRICARE model of 20 days. That TRICARE model of guaranteeing distance and time, we use the same distance standards as TRICARE, guaranteed that veterans would not have to wait too long or drive too far. If they need to be seen immediately, either emergency care or urgent care, they could be seen immediately. They would have to wait for referral authorization, but they did have to get a referral authorization through the access standards or some best medical interest or other eligibility criteria. That was very successful in its first year, both in plain claims. What wrecked kind of a monkey wrench in that system was COVID-19. The whole country, veterans were afraid to get health care, and it was very unclear, both to the VA staff and to the veterans, how community care would work in the access standards. And so there's been a number of hiccups in terms of following the access standards and making sure that it worked. I can tell you though, in the TRICARE Prime system, as a patient, we have not had any of those problems. Now that VA has been coming out of that, there's been some IG and GAO reports about some long wait times to get the referrals as VA is trying to recover from the COVID-19. The last part of your question is about the experienced veterans. To understand the difference from 1996 to now, we have a whole different type of veteran population. In 1996, we had World War II veterans, Korean and Vietnam veterans. Most of the World War II veterans are gone. So primarily we have Vietnam veterans, and we have Afghanistan veterans. We have the post 9/11 veterans, Iraq veterans. We also have half active duty, half National Guard, Reserve, which was not the case. These are the folks that go to war and come back to jobs. And we have a large female population, about 15% in the military and about 10% now in the veterans population at the VA. So we have a whole different type of veteran now with a whole different type of experience, technological savvy, and expectations in terms of being able to get choice, being able to pick the providers they want, and not being, shuttled around by a bureaucracy. So a different system that's been struggling lately because of COVID-19, and a whole different kind of veteran population demographics that has different expectations on the type of care, how they get their care, the access, self-service functions, and those sorts of things. And VA is trying to catch up with that as well.
Yeah, tremendous amount of change in a matter of a couple of decades. You mentioned the Veterans Community Care Program, the situation and the impact of COVID-19. I'm an Army vet, and like a lot of my peers, my veteran peers, I use the Veterans Community Care Program. And I was shocked, just a personal anecdote, I was shocked when I called the community care office this spring, and I was told I wouldn't be able to access my local private clinic, even though they were seeing patients. So I couldn't go to the VA, I couldn't go to my local clinic. And thankfully, I don't have a serious condition. I know a lot of other veterans across the country were stuck with nowhere to go at that time. So I think work to do here. I want to move on to the next question. Thank you, Darin, for giving us that history. I want to talk about the VA Mission Act and choice, generally speaking. From the creation of the original choice program to the today current VA Mission Act reforms, there's been significant changes to how care is delivered and coordinated by the VA over the past 10 years. So the question for our healthcare providers here, as providers, what have your experiences been from these reforms in the VA Mission Act? Is it working? Is it not working?
This is Kat Lindley, and I'm a direct primary care doctor in family medicine. I also work in rural health clinic here in Palo Pinto County, and we do see veterans as part of the Mission Act. We're actually seeing them even during the Obama years. And like you guys talked about, it has been a struggle for them because they need to get the approval. They get 10 visits, and then we see them and take care of them. And I think now during the COVID, it was very much harder for them to be able to be seen, and that they cannot go to urgent care. They have to go to the ER sometimes. And one of the reasons, we can talk about that later, but one of the reasons CHIP actually presented a new bill in Congress was to try to introduce direct primary care as part of this choice, because in the, I call it traditional system. Traditional system is you're sick, you come to the doctor, and we take care of you, we bill it to the insurance in your case, it goes to the VA, VA pays the clinic or whatever. In my system, whether I see you or not, I'm paid because I'm paid monthly, which means I don't necessarily have to make you come all the way to the office, and you have a lot better access. So we're trying to introduce this model into the VA because I have a lot of friends who are veterans like you guys, your ages, and some that are older. I found that a lot of times they just have these medicine dumped on them and they don't need them. I had some on 20-some medication. One guy was taking 128 pills a day. I can't remember to take antibiotic, which is 20 pills for like 10 days. I forget it myself. I'm a terrible pill taker. Can you imagine 128 pills a day? So in direct primary care, the guys that I see, they just have to call me or text me or say, I'm not doing well. Then I'll call them and we'll see what's going on. So I kind of find that there is a lot of, the system is good. I'm glad there is more access, but there's definitely a lot more work that we need to do.
Mm-hmm. Dr. Held, is it working in your opinion, or are there things that you feel need to still be worked through?
I think that it's a great improvement over what was happening, 6 years ago, when with all the things in Phoenix and all the things that were happening. And also the fact now that with some of the things that President Trump has done through executive order, that they can fire employees that are not doing the right things. And so I think there's been some tremendous improvement from the VA standpoint. Also from the doctors that I see choosing to go work at the VA now. I am just so impressed with wonderful doctors that I know, and the patients love and are developing long relationships with those patients. I think if we want to try to continue some innovation, I think the Mission Act has been great, but it would be nice to also, just like Dr. Lindley's talking about direct primary care, to allow some of us that are in direct surgical care to be more involved. So when someone's going in and they're having to wait a long time to have something that's a pretty common surgery, particularly in veterans that are getting older, like cataract surgery that I do, that they would have an option to engage with more community physicians and without so many middlemen. Again, you have to go, the way that I was seeing that it was structured is having to go through a third-party administrator and basically go through an insurance company before you could go directly to the doctor. And it would seem like if we could cut out some of that, some of those hurdles and obstacles that are, again, coming between the patient and physician, that's somewhere that some good work would be able to do, especially in somewhere like Texas, where there's a lot of patients out in rural Texas, not around a VA.
Cutting the red tape, if you will.
Yes.
Representative Roy, your office, you work with a lot of veterans. You represent a lot of veterans. Do you think that the community care program has been improving that quality and timeliness of care for those veterans.
Well, thanks for having me on. Thanks for putting this together. Really appreciate CVA, Kris with AAPS and Kat for being on it. Dr. Lindley, I should say, sorry for being on this. I really appreciate it. Let me just say for both Dr. Held and Dr. Lindley, there are no greater warriors out there for what I like to call healthcare freedom and ensuring that we can get access to the healthcare we deserve. All of us, civilians, veterans, active duty, and making sure that we cut out all of the middlemen, the insurance bureaucrats, the government bureaucrats. I'm a conservative. Conservatives done a good job of villainizing government-run healthcare, but we haven't done a good enough job villainizing insurance-run healthcare. And I want to get all these folks out of the way, and I want to get people going direct to doctors, getting the care they need, what we call personalized healthcare. And these two doctors are fantastic at that, both in their practice as well as in pushing policy. CVA has been a great advocate for massively reforming our healthcare system overall, including that for veterans. And that's why, and I'm saying this for a reason. We're never going to get the quality of care we need for veterans if we don't fix our healthcare system overall, because they are a product of a broken healthcare system. And going to healthcare for the VA, there are places where having specialized care of the VA makes sense. And having that product there and being able to make sure we care for our veterans that way. And we want that to be streamlined and expedited and to work the way it should. But we also want to have all of our veterans be able to go direct to the doctor of his or her choice to be able to make sure they're getting the care that best suits their needs in the easiest format and the best format possible. And, Choice took a step in that direction. Mission then sort of cleaned it up and I think took a much more giant step forward. And we're seeing great strides, great progress. There's some 727,000 different community care providers that give our veterans now options. So they're not having to go simply to a specific VA. We're blessed to have very strong VAs in Audie Murphy in San Antonio and Kerrville facility where our veterans are able to go and get good care, but they still run into obstacles and bureaucracy and they run into limited options. And we want to maximize options for veterans and all Americans. So that was what was behind, as Kat referred to, again, sorry, Dr. Lindley, introducing HR 6259, which we call the Veterans Access to Direct Primary Care Act. I want to make it easier for veterans to go get that kind of care, being able to go have a doctor. And you picture it sort of the black bag doctor, your doctor that you have a relationship with, and go be able to get the care of your needs for $50 a month or $100 a month or whatever it is, depending on the market, and be able to rely on that and have a cell phone number and have a person. You're not just calling some kid on Omaha, Nebraska, who's checking a sheet of paper saying, well, this doctor's in network and you're going to have to drive an hour and a half to go get this care and you're going to be able to get these drugs, but with this drugs, but with this. Nobody wants that. That's not healthcare. And we've got to do a much better job of improving that. And so I'd say, to answer your question, the Mission Act has taken a giant step forward to opening that door to allow veterans to be able to go get the health care of their choice. But we need to now make the system work, and we need to make it better so that our direct primary care access, so they have more options to be affordable to them, and frankly, much more affordable for the taxpayer if we free up the system to work the way it should. And importantly, and we'll get to this in a minute, and I think you're probably going to ask, I bet you'll ask questions that'll touch on this. We need to talk about the technological side and the barriers and the obstacles in the VA to being able to freely go in and out of the system and be able to have your health records and be able to go control your health care as a veteran. But again, it's a subset of our overall problem in healthcare. And I just applaud this whole group for having this conversation.
I want to dig in.
Nathan,
Yes.
I just want to add one thing. I actually do provide community care clinic to VA patients who don't want to travel to Dallas. And the biggest need is actually expanding that community care. I feel that that's where Mission Act, like Darin said, is lacking somewhat, and we need to get more providers and more physicians to sign up for this community care.
Indeed, more participation in it. I want to dig in a little bit to this idea of healthcare choice. There's something that's just fundamentally American about being able to choose our healthcare provider. It's something that when you look at polling, 9 out of 10 veterans support this, overwhelming support for it. Representative, I want to ask you, does this principle resonate? Talk to me about this. Why does it resonate so much in the veteran community, this idea of choice?
Well, again, and I focus in on veterans because it's so important, right? That we all know we feel the obligation, and I serve on the Veterans Affairs Committee. We feel the obligation to ensure those who put their lives on the line and are dealing with any healthcare consequences as a result of that, that they make sure that they're getting the top-notch care. Right? We have an obligation as a country to do that. We also recognize as Americans as a whole, civilians, active duty, veterans, we recognize that it is having choice and options and freedom in your decision making that maximizes quality and lowers costs. That is the American way. And if we don't stick to that, then we're going to be just like the rest of the world. And we're going to, frankly, lower everybody's standards because America's been carrying the rest of the world on our backs for quite a while. And we got to make sure that we continue to be on the tip of the spear, giving our veterans choice and our civilians choice so that you can get the health care that you want and that's best for your needs. And I think that it's important to veterans. Of course, 9 out of 10 support it. It's what they fought for. They didn't fight to have some bureaucrat tell them what the hell they're going to get for their health care. Why would you fight for that? Doesn't make any sense. And this is what really kind of gets me. It's like we get out here and we talk about all the greatness of this country and fighting for freedom and liberty, and we use these big words, but then we don't allow it to occur in the area that is the part of the economy that is, 30% of our economy, whatever the big number is for healthcare, but it's central to us as people, right? I'm a cancer survivor. I had to go talk to a doctor and figure out what was wrong with me, get me fixed. And that was 9 years ago. I was cancer-free 9 years ago this week. I'm blessed for that, but I want everybody to have that option. Go to the doctor of your choice and then have the insurance you need or have the other ways to defray costs. There are other ways besides insurance, by the way, to defray costs and be able to go get coverage and care. We are allowing people to use fear and panic to destroy the greatest healthcare system in the history of mankind, rather than focusing on empowering individuals with personalized care to control their healthcare. We need to have expansive health savings accounts for civilians, but also veterans. There's no reason we can't have a model that works through the VA system, allowing them to have the power and the control of the resources to get the care they need. And look, everybody I talk to, again, civilian, veteran, active duty alike, they all want that. They want that kind of personalized care and choice. So let's do it. It's the American way.
People really want that choice. Darin, I wanted to ask you, because you've been deeply involved in creating and implementing some of these reforms, and already one of the bigger themes that came up here was direct primary care, right? What are some other additional reforms you would make to the Veterans Community Care Program to improve access and the quality of care for veterans? Or if you were gonna advise a lawmaker on doing that, what are some of those things that you would do?
Yeah, a couple of things. First, there is what has not been fully implemented in the Mission Act, which is patient education. And so most veterans don't understand yet, because they haven't been fully educated on how this works, how to use the system. And a veteran who knows how to use the system will be able to do more options. For example, most veterans don't know they can schedule their own appointments in the community. Most veterans don't know that they can take the recommended clinician in the community, or they can find another one in the network and select it. These are all the things that we can do in the TRICARE Prime system that my wife and I do currently. But veterans don't know that. Simply understanding that and doing that gives you a lot more choice, because if the specialist at the VA is still too far away in the community, you can pick one that's closer, or you can pick one that has a availability much quicker. So that's important. The other thing is because of certain considerations in the system, we did not fully implement the Commission on Care recommendation number 1, which the rest of the country knows as their normal healthcare system, their normal HMO, their normal managed care system, which is simply like urgent care. You should have full choice in the network. You should not need an access standard. You should, at all times, the facility should just be part of the overall network, and you should be able to go ahead and pick, whether it's your primary care or your specialist, who works best for you. And if it's the VA, great. Normal managed care protocols, primary care and referrals, all that's the same. The difference in the Commission Care recommendation is you don't have access standards, because like the rest of healthcare in this country, you can go ahead in the plan, pick the provider or the specialist that you want, and not have somebody else have to pick it or need an access in. And so ultimately, that's where you want to go. We costed it out in the Commission on Care. It's really not much more expensive, and you can mitigate the cost by doing normal cost mitigation that you do in private industry with co-pays and other things in terms of utilization. It's all very affordable. It's all been thought out. That is what I would recommend to lawmakers, is to finish the modernization process so that 80% of veterans have other health insurance. They know how to do this through Medicare Advantage. They know how to do this with their employee healthcare plans. It's not new to veterans. It's just not being done in the VA.
So not only are we looking at the potential of an increase in quality and access to care, but savings for taxpayers. I think people could get behind that. I want to move.
That's why we set up a Center for Innovation, like CMMI, so that we can test this all out before we expand it to the whole system.
I want to move to our next question. So recently there was a report released by the Government Accountability Office that expressed concerns regarding the VA's failure to track wait times for the community care program and insufficient staff at VA medical centers to manage community care. So for anybody who wishes to chime in and answer, do you support that proposal by some in the House Veterans Affairs Committee to mandate community providers that to meet certain wait time criteria? Is that something that you all support?
So I'll jump in here real quick, but I would love to hear particularly Drs. Held and Lindley talk about this. But look, I'm not a mandate guy. I don't like government bureaucrats coming in and telling you what a schedule needs to look like, how long it should take. Just get out of the way. Allow the market to work. Empower veterans, empower civilians, empower Americans to be able to go out in the market and get the healthcare of his or her choice. Period. And then go to the doctor that is quicker and better and higher quality. Just like you would when you get your oil change, just like you would when you get your painter for your house. Don't overcomplicate this, right? If you're going to a doctor and it's a 40-day wait time, go to a different doctor. That's a 15-day wait time. And that's how it works. And so we need to do that empowered. Now, should we have studies that, track the wait time so we can better figure out how to provide policies through the VA? All right, sure. GAO, go do a study on wait times. I'm fine with that. But it always worries me because they can then be used as a club to say that there's something wrong with community care, when it's not community care that's the problem. It's the obstacles to getting the community care, right? If you can't go to the VA and get your health record and get approvals through the VA to go to the community care provider to get the care, well, then it ain't the community care provider's fault. So I think we just need to free up and empower the veterans, give them the power to be able to go out and get the care they need. If they got an eye issue, go to Kris and say, look, I want to get this procedure done. Kris will say, well, it'll cost you this, and I can do it on this date. And they can say, great, sounds awesome. Or they can say, well, that's too long, and somebody else will do it cheaper. Why do we complicate this stuff, right? That's what we want. Get that for everybody in America, but particularly our veterans.
Dr. Held or Dr. Lindley?
Actually, Dr. Held, if you don't mind, I would like to take this. So, Darin, you said a lot of great points, and I agree with you, but you're kind of coming from that bureaucratic side. Let's do studies. Let's put more people behind this. Let's approve this. Let's approve that. And then CHIP comes from more my side, which is the first thing that needs to be done is empower the veterans. They're the ones, this is their health. It's not yours, it's not mine, it's theirs. We need to teach them to be their own advocate, to demand what they need and what they deserve. The second thing is actually not to do more steps, not to mandate things, not to make these studies and things like that, because how many more people do I have to hire for that? And where is that money going from the VA budget? I can tell you from, my husband is a pain management specialist, and there are other specialists in our community. They were not taking the VA patients through the community choice program about 2-3 years ago. I don't know now, but 2-3 years ago, they were not taking them because the VA was not paying the bills. So if you want to improve the community care in your area, I'm not saying that's true now, I'm just saying about 2-3 years ago, The reason specialists were refusing to take veterans because VA was not paying the bills and no one paying these bills. So those are the things that need to improve. We need to really have more accountability. And you need to give the power to the veteran. Let the veteran decide if Dr. Held is better ophthalmologist than someone next door to her, or if I'm better family medicine doctor than someone next to me. It's like all these mandates and all this red tape is what's costing VA money, and it's not going into the veterans' care. It's going into the bureaucracy, and there's that circle. You know, I come from Yugoslavia. You guys can tell from my accent. I come from socialized medicine, and if you do more things to make this red tape bigger and bigger and bigger, the actual healthcare part, the actual medicine part gets diluted because you have to pay everyone behind me. So I just want people to always keep that in mind.
And I'll just pipe in a little bit too. From my standpoint, I want to spend my time talking to my patient, having a patient-physician relationship, not checking off boxes and making sure that I can apply to be in another network. I mean, all they've done now is they've got the VA, and then now they're introducing a whole nother set of third-party administrators and bureaucrats. You know, if you look at what happened in 2017 alone with insurance and all these third-party people, $800 billion were spent on administration. Let's spend that money directly on the patient. I am so humbled and honored with every veteran that I see. It is my great privilege to see them and thank them for their service. And I want to take care of them directly. I want to have a patient-physician relationship. I don't want to know that I can't do that. I'd rather have them come in with their health freedom account or their personalized account and be able to choose to see me. We have a relationship, we have an agreement, and then they can deal with the VA. Why can't we put the veteran at the center, not the VA hospital? I remember when everything was inpatient and people, they said, if you want to have something, you go to the VA hospital, everybody show up at 8 o'clock and let's see what happens. We can do way better for the veterans now. We talk about innovation, things are outpatient now. Let them have the choice. And if they don't use that money, then they can keep it and go forward. We could be innovative with this with the veterans, just like everything else, and save money for the patients, not bureaucrats and administrations. The veterans deserve it.
A follow-up on this for Dr. Held and Dr. Lindley, would mandating things like wait time standards for community providers in your situation add red tape to the extent that it would disincentivize people in your position to participate in the veteran community care program in the first place?
I don't think it would. And, you know, I think having standards and saying this is what we expect from you is understandable and should be done. But, you know, mandating, I kind of agree with Chip on this. It's just one of those things that's going to turn people off. But saying, you know, if you want to participate in our network and things like that, sure, you know, those minimum standards need to definitely be taken in consideration. But to give you an idea, waiting time with someone like me or with Dr. Held for veterans, especially, it's 0. I went to see patients at 11 o'clock at night if that's what's needed. And that's where, you know, someone who does direct care or which Dr. Held does, or direct primary care that I do, we understand that it's not about these wait lists. It's not about I'm not going to call you now, leave a message with my nurse. It's about that person that needs help. And I think that's kind of where the standard has to be. The standard has to go back on the patient. We need to do the best choice for the patient and not for everything else.
Well, let me add to that. There's a lot of confusion lately at a recent HVAC hearing about wait times in the community. So as one of the folks that helped write this, what's in the actual Mission Act is really meant to be a wait time goal and a wait time standard for the network itself, not for individual physician, so that the VA would build a strong enough network so veteran would not have to drive too far or wait too long by having a really big, robust network. So that if one doctor is not available, either too far or too long of a wait, which what happens commonly, if I call for my dermatologist is on vacation, they say, do you want to wait or do you want another dermatologist to practice who's available in a couple of days? that's the idea of the wait time standards, is to make sure that the TPAs build a network strong enough so that due to the strength of the network, you never have to drive too far or wait too long. That's the whole key to that.
So let me just jump in here real quick to add. So because I hear where Darin's coming from, and I appreciate that, and we've had these discussions in the Veterans Affairs Committee. I think where I come from on it is, last week we had a hearing on Cerner and the implementation of the technology at the VA and how that's going to then impact all of these healthcare issues. And the question I asked at the very end of the hearing, and I asked a bunch of technical questions about it, from an RFP standpoint and production and systems life cycle and all that crud. But at the end of the day, the most important question that I asked was, 12 years ago, an iPhone was new, right? It didn't exist. It just came onto the market. And now what can you do with this? In 12 years in the free market, what can you do? You can go order a plane. You can have a private car, come up and show up at your house and take you somewhere, right? You can check all sorts of healthcare issues, blood pressure, monitor, and diabetes, and all sorts of stuff, all in 12 years from a phone, right? We had a flip phone 12, 13 years ago, and then somebody said, oh, there's this thing, it's an iPhone. Oh, and this is cool. And what happened? The market produced all of this stuff in 12 years. But what we do in our bureaucratic way of doing things in the government, and what we're doing right now with Cerners, to be honest with you, right? We've got this massive RFP to roll out this massive healthcare system, this massive system that, the question I asked was, when can you tell me, VA people and Cerner people, when will a veteran, all veterans, every single veteran in America, be able to say, I can go get the healthcare that I need to go get instantaneously, go out there and get my records and go out and get healthcare, right? And none of them wanted to give an answer, right? Because that's the actual question that matters, right? The question that matters is empowering the veteran to be able to go straight out into the market or into the VA and go get care. Not like a member of my staff who has PTSD and called to get a consult for dealing with the PTSD, and was told in June that they could get to him in end of September, right? So we can put mandates on and we can do wait time analysis and stuff. We need to just empower the veteran to be able to go find the best doctor, wherever you can go find the best doctor for the price point that works for you, so you can go get care today. So you can go get care tomorrow. And that's the way I look at it. And I'm not arguing with your point, Darin, because I agree. We need to have, oversight. We need to pay attention. We need to give standards about what we expect in terms of weights and so forth. That's fine. But I think at the end of the day, our goal ought to be to not be worrying about all of that. We should study it, look at it. Hey, how long it's taking? Get reports. Like, are you getting the care you need? Because we're using taxpayer dollars to subsidize it appropriately for veterans. But I think we need to focus like a laser on providing the tools, the resources, the flexibility for our veterans and our patients to be able to go get the care of his or her choice.
Representative, you just mentioned some of the technological tools VA is trying to implement. You mentioned the Cerner initiative. I know VA is giving away tablets for telehealth. Can you, from your perspective, tell us a little bit more about what VA is pursuing? Are those initiatives putting the veteran in control, or can VA do better to implement those technological initiatives in a way that does that?
Well, it's a government entity following laws that were passed, historically. So of course it can do better. That's always the case, right? It's why I want to try to remove that and get that out of the way. That being said, are we headed in the right direction? Yes. Are we doing things to figure out how to empower veterans who need it? Yes. Are we, through Choice Then Now mission, some of the things you're talking about technologically, what we're trying to do with Cerner, is that all heading in, again, the right direction? And is Secretary Wilkie and is the VA pushing hard to try to empower veterans? I believe so. I think we need to go farther, faster. I think we need to push hard to have more, synergy with the private sector to come up with ways for, all these brainiacs out there in the private sector to bust loose. That's why some of the questions I was asking Cerner was, I don't want them to get stuck. I want to make sure that the APIs and all of the, technology is flexible. so that when we have different, apps and different ways for the market to provide better ways for veterans under all the HIPAA requirements, all the things for privacy, to be able to go get their records, go get what they need, and go, all right, and get approvals to be able to go get the care of their choice. That's the biggest barrier, in my view, is giving them total flexibility and total ability to have control of their health records and their technology to be able to seamlessly move in and out. Say, hey, here's something the VA provides. Maybe it's a trauma thing, right? Like head trauma. We've got specializations at Audie Murphy in San Antonio where, that's particularly designed for our veterans that have had massive injuries when they've been serving our country. But if you want to just go get a flu shot, or you got a sprained ankle or busted knee, whatever, I mean, just go down the road to your doctor and get care, and just be able to seamlessly go down there and get the care and pay your DPC doctor your $50 a month as part of your VA service and get care. And we got to have the system capability with the policy backing to make that work.
We're talking about putting veterans in the driver's seat, putting them in the middle of their care. And I think Dr. Held or Dr. Lindley mentioned an initiative that you're working on, Representative. A few months ago, you introduced legislation to give vets increased flexibility to access prescriptions from community pharmacies during a public health emergency like the one we're experiencing with COVID-19. Why should VA give veterans this type of flexibility to pursue these community solutions and get those prescriptions filled through a local pharmacy during an emergency like this?
Well, I think both the doctors, as well as probably Darin, could probably even speak more directly to this. But I'll tell you that after talking to numerous doctors, a bunch of veterans, and some of their concerns, not just this pandemic, although that certainly drove the thinking. But we introduced, let me get the number here. I have too many bills with numbers here. Remember, HR 6997, the VA Prescription Flexibility Act, and it would waive the 14-day supply limit during a national public health emergency for non-VA facilities, and allow veterans to fill the prescriptions for up to a 90-day supply, right? So they're not having to just go back and forth. You should also be able to fill those prescriptions at a place that's nearby and easy and convenient for you. I think we need to be going in that direction more broadly. That goes back to my main point about flexibility and options. I realize there's sometimes some limits to what you want to be able to do, and then doctors could speak better to which prescriptions you should be, what can be allowed for longer terms versus not. Certainly open to all those conversations and debates. But again, that should be up to the doctor, right? I mean, we have licensed professionals for a reason. And at the end of the day, for both veteran care and civilian care, the doctor-patient relationship should be 90% of our entire healthcare conversation. The rest of it is noise. And we've got it right now where we've got insurance bureaucrats are the people you have your relationship with more than your doctor, right? When you're going out and trying to find care. We don't want that for either veterans or civilians.
Gatekeeper standing in the way. Doctors, you both directly work with patients who need medications from time to time. Can you tell us a little bit about your perspective on loosening these restrictions around where a vet might be able to get a prescription filled?
I think, I have, like I told you, they would come to the community care clinic, and I was their primary care doctor during that time. I would send refills to the VA, and they would get those refills, which was fine because they would always come in time. But then when they have acute illnesses and stuff, you need medication right there and then. And few times I had few veterans who were afraid to go to the local pharmacy because they were afraid how much it would cost, if they would get the money back. And if I put someone on antibiotics for pneumonia or something, and if I choose something that's not generic and not cheap, but they need it, it becomes an issue. And then especially during this pandemic where we had issues with the mail and all that, I think there are times where these things really should be loosened. And sure, like if they're on opioids or different things and they need to pick them up somewhere else, that's different. But there needs to be, at the end of the day, the only person we need to care about is that veteran. And how do we make his life easier? Because some of them in the Mineral Wells area, there are a lot of veterans from the Vietnam War, so they're elderly, and trying to get them the medication and how they're going to get it. It was a burden for them. So I think it's really important. And before, Dr. Held has probably better insight on that as well. But one thing I want to say about those Chromebooks that you mentioned that they're getting right now and getting more access, that's great. But who cares if they cannot get the actual physician? Because, you know, when we talked about his staffer who needs 2 months to see someone in mental health to help him, how many veterans have we lost? How many do we lose a day? You know, that 22 a day that everyone talks about and stuff. How many do we lose a day if they don't have access? So having that Chromebook is great. I think it's a wonderful thing, but they need to be able to actually talk to someone.
Which I think ties us back to Darin's great point about tracking the wait times. You know, it doesn't help us for him to go all this great work and we have these bills, we have these acts, and then there's not enough doctors. So there has to be a better way to do that. And I think putting the veteran in control of it, they can be the one maybe that says this just does not empower them to be the ones to say, I'm not able to get in with a doctor. We need more doctors at the VA or in the community. And the same thing with medications. We need to make it easy. And we need to, along with what Congressman Roy was saying, we need to know, you know, what is the formulary that we're dealing with? And this all boils back, going back even to what we're talking about, putting us in control, not just with veterans, but with all patients across the United States, getting out, you know, these middlemen and people that are deciding what's going to be on what formulary for who, and letting the patient make the decision and the doctor. And so all these things are working, but it's not easy. It's complex.
Darin, you had something you wanted to share.
Yeah, I just want to add complete agreement with the doctors and Representative Roy here. The reason VA has its 14-day limit really is because they feel they can get pharmaceuticals cheaper and they want to save money. Now, if you're a veteran that's in a rural area and you have a 2-hour drive to the hospital, do you really want to have to drive 2 hours every time you want to get a prescription refill? There can be problems. I hate to keep talking about TRICARE Prime, but as a TRICARE Prime patient, I don't have this restriction. It's cheaper for me to go to Camp Pendleton, but if I don't want to, there's a whole list of pharmacies I can go to that are tied into the DoD system. And yes, I'll pay a little bit more of a copay to go to Walgreens or CVS, but I can do that. There's not a 14-day restriction or a 90-day. It's all up to me if I want to go to Camp Pendleton or if I want to use the Walgreens or whatnot. And I think it should be the same thing with the veteran. They make the choice that's best for them, as long as they understand what the co-payment structure is. And there are co-payments at the VA also as well. So in full agreement, the VA is just a control issue. It's a cost issue in their head, but these things can be mitigated, especially if you have a primary care doctor in the community. You should be able to pick and choose where you get those prescriptions.
So everyone here is an advocate of increasing choice, I think, fair to say, and you've all been advocates for some time in increased flexibility generally for healthcare for Americans across the country. So I think we have time for one more question here. My question is, how would legislation like the Personalized Care Act that Representative Roy introduced give individuals more healthcare freedom by expanding health savings accounts?
Well, I guess since I introduced it, I would at least kick it off. But look, I didn't introduce it on an island. I've talked to both of these two doctors as well as dozens of others and healthcare providers and folks representing insurance companies, and then of course my constituents about what's so critically important. Now, look, you know, things we have all these jargon, you know, about bills and names and fancy names and DC and our titles and all that. What does this actually mean? All right, when we introduced the Personalized Care Act, the purpose of it was, as I stated earlier, to empower patients so that you can control your healthcare, right? And that you own it with your relationship with your doctor. And at the end of the day, you frankly, you kill the whole problem with pre-existing conditions if you put patients back in charge of their healthcare so that they can go afford healthcare directly with a doctor and be able to then take whatever they've got in terms of direct primary care, insurance, catastrophic insurance, et cetera, and take it with them instead of being tied to a particular job. And the model, you know, we've had health savings accounts for years, but frankly, they've been tepid. We've been nibbling around the edges. They can't really work if they're not central to the healthcare model. So the idea behind the Personalized Care Act is not just let's beef up some health, savings accounts. No, it's to fundamentally transform healthcare so that you've got control of those assets. And how it would work: you'd have a robust health savings account that you can contribute to on a tax advantage basis, that your employer could contribute to on a tax advantage basis, the same way they do now when they write off the insurance policy that they have with Aetna or Blue Cross or whatever. It would allow for other options, charitable options. It would allow for potential government options. You could have potentially VA dollars that go into a health savings account so that you end up empowering the American, whether they're a veteran, civilian, active duty, or whatever, to be able to control that. And so now you've got that. And just like you do your auto insurance or your homeowner's insurance or whatever, you carry it with you through life. You carry it with you rather than it being tied to your employer. Your employer can still subsidize it. That's awesome. We're for that. Your employer can provide direct primary care on site. Fine. We're for all of that. But we want options and flexibility that empower the individual American and their families to be able to control healthcare. So just imagine that, this bucket that's got all the resources in it so you can go shop. Now suddenly you've got transparency. Suddenly you're in control. Suddenly you're in charge. And you can take those resources and get what's right for you. And then for anybody who falls through the cracks, we've got the ability to have guaranteed coverage pools so that you can then take people who are in the risk category. I'm a cancer survivor. I lived through that. So that if for some reason you lost your insurance because you just couldn't afford it and you had bad luck and dwindled down your health savings account and charity couldn't pick up, or health sharing ministries or whatever. And by the way, that would be a very fractionally small percentage of the population if you look at the numbers. We'll take care of it. And we've got the way to do that through guaranteed coverage pools. That would fundamentally transform healthcare in such a positive way to drive down costs, increase transparency, increase choice, empower individuals, and give them the chance to go out and have the best healthcare in the world continue for their kids and grandkids. That's what personalized care does, in my view.
I agree also, if you make if patient is in charge of their own healthcare, patient is going to make smart choices. And you can bring it really down to buying a car. If I want to buy a black GMC Denali or a white one, I want to pay $5,000 more because I want a really black one in this place. I'm the one that's in charge of my money. I'm the one that's going to choose. Healthcare is the same way. And if Kris and I are competing for the same patient, we want to give him the best care we want. We want to decrease the cost. So the cost is going to go down, quality will go up. It's really all about patient making his or her own choices. They know what they're doing. And it's really as simple as that. Patient knows what they're doing, physician knows what they're doing. Let two of them decide what to do about their healthcare.
Yes, I would definitely agree. Anytime that you have choice, and transparency, you have competition, and it keeps everyone on their toes, doing the best they can from their office staff the minute the patient walks in that door until they leave with their medication and their best care, and telehealth and having their doctor's numbers and that personal relationship. And there's nothing that's a substitute for that. Nothing. And then the patient, whether it's a veteran, a civilian, active duty, as Congressman Roy said, they're the one that's the judgment of that quality. They want to pay a little more and drive across the street or what's important. They can make those decisions in their particular individual situation. So it's a great way to kind of work toward.
Well, let me just add one other point to that, if I may. I know we're probably running out of time. And Senator Cruz is the sponsor of this legislation in the Senate. We've got a pretty good, solid group that are behind this. The Republican Study Committee, which represents a big block of the Republican House members, are behind this approach, as well as some other pieces and part of the Republican Study Committee plan. When people say Republicans don't have a plan, we do. And it's a great plan. And it's a plan that the American people should get behind if we'll trumpet it and explain it. And one last point. We will not save our country's debt problem if we don't get healthcare costs under control, period. End of story. The only way to do that, it's not to have some magic reform of entitlements and Social Security, Medicare, and all these things. It's to we need to do all that. We need to get our healthcare prices down. And you get healthcare prices down through competition and choice. If we don't do that, 27 trillion becomes 30 trillion, becomes 35 trillion, becomes 50 trillion, and our country's bankrupt. We have to do this. There's no option. We have to inject freedom, transparency, competition, options for individuals, and we'll have better healthcare, better outcomes, lower debt, and our country's a lot better off.
Choice and competition, the theme of our conversation tonight, I believe. This has been terrific. These are the conversations we've got to be having more of in America. These are the kinds of debates that we need to have more of in Washington. And Representative Roy, thank you for being a champion for veterans and a champion on these issues. It goes such a long way. And Doctors Held and Lindley, thank you for contributing your perspective tonight. I think it really helped round out the conversation. And of course, everybody, thank you for your time. I know it's a precious thing these days, but we're very appreciative of that. So thank you for that. I also want to thank, as we close out, the Concerned Veterans for America team, the staff who made this possible. They put a lot of hard work into these, coordinating and taking care of all the technology in the back end. They make it possible. So thank you all who worked on this. And all of you, our audience, joining in, thank you for tuning in. We hope that you'll stay connected with us at CVA, Concerned Veterans for America. If you want to learn more about what we do, what we stand for, I encourage you to check out our website. That website is cv4a.org, CV, the number 4a.org. We're also on Twitter at Concerned Vets. We're on Facebook, Concerned Vets for America. Follow us, interact online, and we hope you stay connected. So thanks again for tuning in. I hope everybody stays healthy and well in the coming days. And we're out here. Thank you very much.